Today I want to show you this very interesting dental implant case. It's a full mouth dental implant treatment, and as you can see here, the patient has a number of different diagnostic findings. He's missing bone in the upper jaw, in the back quadrants. He's also missing bone around the teeth between 40 and 50% in the upper jaw, and missing bone in the lower jaw between 20 and 40% or so. He's got a broken tooth here that has a cavity. He's got root infections here, here, and here. So the diagnosis name for this problem is periodontal disease, and that is a disease that causes ongoing inflammation of the gums, leading to bone loss. He was given the option to only do his upper arch at this time. He chose to do both arches, but he could have waited on the lower arch, and that's one of the ways we try to give patients financial options so that they don't have to come up with all the money at one time. As you can see here, he definitely has aesthetic compromise, leading him to want to improve his teeth. He came in wanting to be able to chew food and have a better smile. As you can see here, he has lost a lot of bone and gum tissue. You've heard the phrase long in the tooth. That implies older patients or older people who have had bone and gum loss, and this is a good example of that. What I'd like you to notice also, though, is that he does have a certain amount of good gum tissue left. In my videos, you'll hear me talk about keratinized tissue, and this is the pink, sturdy, healthy tissue that should be around the natural teeth. His is average to below average, but one of the amazing things you'll see at the end of the presentation is how much better the keratinized tissue quality gets through a number of different techniques that I use. And here you see both jaws coming together, and I'd like to also demonstrate again just how much good keratinized tissue he has in the lower arch as well. This is really important in the overall success, aesthetics, and general outcome of implant cases. Here you see some pretty significant wear of his lower teeth, meaning that he grinds his teeth. This was an ongoing problem for this patient, not just preoperatively, but during the use of his temporary bridges. He was in pretty frequently for repairs, and when he was here, I could even hear him grinding his teeth during waking hours, just in the middle of the day, even at his dental appointment. And it was no wonder he did have problems with breakage of his temporaries, that is. Please excuse the gory slide, but I want to show you here what we do after we take the teeth out. We find ideal places, or what I call strategic places, to place the implants. On the back of his mouth, he did not have any teeth, but he did have good bone to place additional implants in the future. His implant stability was surprisingly low, meaning that the bone density was low and the connection between the implant and the bone was not real solid. So I was unable to give him fixed temporaries that day. I talk about this in a lot of my other videos as well, by saying that as long as we achieve a perfect outcome, I ask certain patients to wear dentures for 2 months if their bone density is not good, and that was the case with this gentleman. So on the initial surgery on his upper jaw, we took out his existing 6 teeth. We placed 4 implants, but I also did sinus grafting on the back areas that were missing bone. This is what it looks like immediately after surgery. Again, he did not have good bone density, and he only had 4 implants towards the front, so I was unable to give him a fixed temporary that day. I talk about transitional treatment with many of my patients who have a number of good teeth, and we will leave certain teeth to give them fixed temporaries for 2 months. This gentleman decided to get everything done as quickly as possible, so he wore temporary dentures for 2 months while the implants were tightening up in the bone, a process called osseointegration. Here's the panoramic image the day of surgery. You'll notice there's extra bone back here now for future implants. That has to heal for at least 6 months prior to putting the posterior or the back implants in. The sockets back here were too large for implants, and because we were delaying treatment on the upper arch, I decided to wait to put these implants in until later when we did the uppers. This is the appearance of his upper jaw 2 months after the initial surgery. And what I like here very much is that we were able to maintain some of this, what we call gingival architecture. It's the peaks and the valleys around where the teeth used to be. And that's important in making a final prosthesis that looks, feels, functions, and cleans just like bridges on teeth. Same day, the mirror view of the upper arch. And again, I'd just like to point out these papilla that have been maintained are crucially important in getting the right contours for the future prosthesis. And you hear me talk about not removing bone, especially in the upper arch. Unlike all-on-4, the all-on-4 technique, we do not remove bone in the upper arch. If you remove bone in the upper arch, you will never maintain any of this gingival architecture, and your contours will never be that like natural teeth. 2 months after the initial surgery, this is what his lower jaw looks like. And even though we don't have great papilla, we have just some semblance of a papilla, which is normal in the mandible. Mandible meaning lower jaw, but do note the amount of keratinized tissue here. This is very, very important for future success. This is the mirror view of the lower arch after 2 months of healing. You'll notice you don't see any implants, and that's because we cover over the implants when they're not tight in the bone, and we come back at 2 months and uncover them. This gives me a really good opportunity to improve the connective tissue or the keratinized tissue around the implants. This is 2 months after the initial surgery where we uncover the implants. These are impression copings that we use to index the position of the implant to get ready for the temporary bridge. And because the implant caps were slightly showing through the tissues, my incision could be very minimal in the upper arch, just basically enough to expose the implants. And again, going back to that valuable, important, precious tissue, this is all the connective tissue that we were able to maintain by not removing bone and not removing tissue. This is the mirror view of the same shot of the impression copings on the implants 2 months after the initial surgery. This is the mirror view of the lower jaw at the time of uncovering 2 months after the first surgery. And you'll notice that where I've got abundant keratinized tissue, I will simply make my incision right through the center of it. But in any place that I have limited keratinized tissue, I will make my incision towards the palate or towards the tongue so that I have plenty of keratinized tissue to put on the outside of the implants. It's a very important finesse point about implant surgery that a lot of doctors simply don't know about or care about. What this slide shows is the impression of the impression copings that you saw on the previous slide. I use a denture or a acrylic prototype as the impression tray, and the blue and purple material is actually the impression material. It registers the impression coping, which registers the position and the timing of the implant. Same thing in the lower jaw. This pink material represents the gum tissue, and you'll see how that works in the next few slides. This is our first implant model. It looks a little crude, and it is, because we're using this just to make temporaries. We'll come back a few months from now and make much prettier final impressions, which will generate a much nicer looking master cast. But what you see here is the stone. It's holding analogs, which are the implant representation in the model. They're little titanium analogs that have the same diameter and the same timing of the implant in the mouth. Then you'll notice the pink tissue that I showed on the previous slide. I now have a representation of the tissue itself. The cylinders and the pins are what connect the temporary to the implants. Those are called provisional copings. By taking a shell prototype, we can start making openings for connecting the temporary to the provisional copings. This is an acrylic. It's called crown and bridge acrylic. It's what we make all our temporaries from. Now I've filled the holes in between the cylinders and the temporary, and we've got this large block of acrylic that now needs to be shaped to look like teeth. Here are his upper and lower fixed temporary bridges. They are not the prettiest bridges I've ever made, but in his case we were trying to make them as strong as possible because of his intense grinding habit. So instead of doing white teeth with pink gums, I made the entire temporary out of my strongest crown and bridge temporary acrylic. I believe it performed better than any other option. And even though it doesn't look beautiful here, what I want you to notice are the gum tissues and how they meet the prosthesis. And you'll follow these along with me during the presentation to see how beautifully they heal. This is the patient's temporaries after approximately 2 months. He's been in for repairs a couple different times, and this is where we started discovering how intense his grinding habit was, period. He would say to me, "Doctor, my temporaries bounce." And I had no idea, no earthly idea what he meant by that. But what he meant was he was clenching and grinding so hard that he could actually feel the acrylic flexing, which is mind-boggling to me. As many years as I've done this, I've never had a patient say that, nor have had a patient that has been grinding in front of me at his dental visits. Typically, grinding is a nighttime habit, and this gentleman could not control his grinding at all during the day or night. So we made him mouth guards to wear at night to help protect his temporaries. It got to the point where he had to wear them during the day as often as he could to protect the acrylic. This panoramic x-ray shows the additional 4 implants that were placed 6 months after the bone grafts and 6 months after the initial surgery. We added these 4 back implants because I do not like to have cantilevers. The all-on-4 technique that you hear all the time on television, or you see on television, they leave their last implant in this position here, or here, or here, or here. And that means there's at least one tooth extended off the back side of the last implant. I don't like that. I don't like to have cantilevers when I can avoid it. So even though it protracts treatment increases the cost slightly, I believe that supporting the implant bridge all the way around is of paramount importance. And even though the temporaries were not the prettiest ones I've ever made, with the lips retracted, they were quite aesthetic when he simply smiled and spoke. This is after a number of different breakages and repairs, but they were hanging in there and they made it through the 9 months that they needed to be in his mouth. In general, the patient and his family and I liked the way the temporaries looked, but while planning for the final prosthesis, we take pictures from all different angles, lips retracted and not, to make sure that our lip support is good, our tooth display is good, tooth projection is good, and then finally we pick a color. Same view as the last side except from the left. This is called an impression jig, and what we do is we place impression copings on the implants and then we connect them all together with a dimensionally stable acrylic resin. This helps with accuracy, and it also gives us a framework on which to wax the prototype. This is the final impression. It picks up that red jig that we showed you on the last slide. So these impression copings give us the implant position, and the purple and blue material show us all the soft tissues. We need both of those to make a proper fitting prosthesis. The same process on the lower is shown here. I mentioned the implant analog, and this is what they look like. The green, the blue, and the silver are lab analogs. They match what is in the mouth. These are titanium devices that you'll see in the upcoming slides represent the implant position and timing. And then again, the soft material, the purple and blue, we pour stone into that and it represents the tissue. Same impression, different view. This is what we call the master cast. It shows us the soft tissues and the implants on one model that should be as close to perfectly like the mouth as we can get it. That's the key here, is that these master casts need to be made with care and then verified at a future visit, so that when we make the final prosthesis, especially those in zirconium, they have to fit each implant perfectly. And that might sound easy to you, but making a glass type prosthesis fit 6 implants or more perfectly and passively takes precision and care. This is the lower arch master cast. Once we have both upper and lower master casts, we then put them on an articulator. This is a device that simulates the patient's jaws so that we're working as close to what the patient has as possible. When I tell you we've got a lot of different shades to consider, I'm not kidding. These are the shade guides that we have to pick from. And we always get excited when patients want to do something that looks realistic. So for a 70-year-old man with a complexion like this gentleman, his opinion and his family's opinion was that he wanted the teeth to be age appropriate. So we also, we're ruling these out completely. I mean, this is just not what he wanted. So we also have a decision to make on the color of the gum tissues. So we've got many different options, and many times I'll tell the lab to mix and match certain shade tabs. But we can give the patient just about anything they desire. Our gum tissue shades are limited, so we can mix and match these as well. In a case like this gentleman's, we ordered denture teeth. which already have beautiful contours, so we're not having to recreate those by hand in wax. We set those on the model in wax over the red bar that I showed you a few slides ago, and this allows us to do a try-in, and we call this the prototype. It's what we're suggesting to the patient that we do in the final restoration. Same thing for the lower. It's a little difficult to see, but inside the pink wax is the red impression jig that I showed you a few slides ago. This gives the prototype rigidity and strength so that when we screw it into the implants, it's not relying on the strength or lack thereof of the wax. This is the tissue view of the prototype. Both upper and lower prototypes tried in the mouth so that he, the family, me, and my staff can all comment on how they look. During this try-in, we take probably 40 different pictures from all different angles, with lips retracted and without. The main thing we try to do is to get patients to animate fully. Many of you looking for implant treatment, or anybody that's been embarrassed by their teeth for any length of time in their life, have trained themselves to protect their smile. Some people can smile without showing any teeth. Some people smile and show half their teeth. But the goal here is that we're making teeth that you're going to be very proud of. So if we can't get a fully animated smile at the time of this try-in of the prototypes, we're not always 100% sure that everybody's going to like it. So I tell really stupid jokes to try to get people to laugh and smile naturally. Because this patient was a grinder, severe grinder, maybe the worst I've ever treated, he was getting upper zirconium. And I don't like to do upper and lower zirconium in somebody who clenches or grinds at all, but especially a patient like this. So what you see here is the upper final restoration in zirconium, characterized in the appropriate color, that which the patient and his family and I picked. And the lower is now the same wax prototype with slightly different teeth to deliver the upper and then get ready for a different type of lower. So in grinders, I like to still do titanium wrapped in acrylic for the lower arch. That way, it's not like glass against glass. With zirconium upper and titanium acrylic lower, the lower will always be softer and kinder to the upper zirconium. This is the right lateral view of the same. This is the left lateral view of the same. This is the occlusal view of the final restoration. Some things to note, how nicely spaced the implants are and how nicely angled the implants are. All of the screw holes come through the teeth without any angle correction, and that's done through abutments. If you've seen any of my other videos, you'll know how much I dislike those and how bad they are for the long-term success of the case. I also want you to notice that the patient elected to go with some slight imperfections in his final restoration. Again, he wanted these to look natural, and that's one of the, not just the color and character, but we can also change the way light refracts off of the teeth by introducing ever so slight crowding, and that's what you see here. This is a close-up picture of the front teeth, and I have to brag about the lab that I use here. Over the years, I've been working with them for 30 years. As of 2023, we've been together 30 years. I don't own or operate the lab. They're independent of me, but they are artists. And in this picture, I'm going to demonstrate a few things that you will never get in All-on-4. This is customized zirconium by layering porcelain over the front of the teeth. You'll notice translucency. Natural teeth all have translucency. In some patients it's easier to see than others, but if you'll notice these little subtle areas of translucency, they diffract light differently than solid monochromatic teeth. In a person who wanted something very characterized, you'll notice right here, I won't go over it because you won't see it if I go over it, but I'm going to go just next to this artificial crack line. Teeth always have cracks. Even natural healthy teeth have micro cracks in them. So we try to simulate those here and there. You'll notice the difference. They're not just flat. They actually have some anatomy to them, like natural teeth do and should. And all this comes together to create a very realistic, lifelike outcome. I mentioned the slight interruption in perfection, and this is just demonstrated here. This tooth and this tooth are just ever so slightly further out than the others. And you'll notice again the translucency that's built into the teeth by layering porcelain, and even this craze line. Now I know a lot of you don't want that, but I try to counsel my patients, especially when you're in your 60s, 70s, 80s, bright white teeth are not normal. We can make very pretty white teeth without them being monochromatic. So I use this patient as an example of what we can do. I'm not going to fight with my patients, but I will counsel them and say, you know, yes, when you look in the mirror, you're probably going to like what you see. But if you go too white, your family and your friends are going to talk about you behind your back. So buyer beware on that. Here's the frontal and top view of the final zirconium implant bridge. And like you've heard me say in many of my other videos, all the contours facilitate cleaning by the patient. Very, very rarely do we ever have to take these prostheses out to clean them for the patient. You'll have areas you can get floss in here if you will. We certainly want our patients to floss these, but most patients brush and water pick, and that is enough because everything is cleansable by the patient. This is the right view of the same prosthesis. And again, I would just point out that all of these contours are cleansable by the patient. Everything's a smooth and gentle, convex profile. The left view of the same prosthesis. This is one of the slides I wanted to get to. Anxiously awaiting my comments about this. So you remember this patient had significant bone loss, significant tissue recession, and had what I said in the beginning was good keratinized tissue. Because we handled each step along the way properly, look at how beautiful these tissues are. We've been able to recreate some of the natural contours, but mostly I just want you to appreciate the volume of good, healthy tissue by not removing bone and not removing tissue like so many of our competitors do. The redness that you see here, that's simply because the plastic temporaries, the acrylic temporaries, sometimes cause people to have a slight allergic response. 1 week of getting the zirconium and this will all be pink like the rest of the picture. This is the frontal view of the same beautifully developed tissues. This is a frontal view with a slight tilt so that you can actually see the ideal depth of the implants. Anything more shallow might show metal, anything deeper would be harder to clean. This is the day that we gave the patient the prosthesis with lips retracted. Here we have on the same day the upper definitive zirconium prosthesis with the lower prototype wax up. Why do we do this? In my practice, the upper's made by one lab and the lower's made by another. We want to make sure the bite is right. So we try everything in one more time and make a new bite record so that when the lower comes back from the other lab, we're not making significant adjustments. This is the lower master cast, and I wanted to show this to show you how we modify the pink. This is actually called polyvinyl siloxane. It's a soft tissue replication of what the patient has in their mouth. And you'll notice this trough that we create. We actually modify this model ourselves before it goes to the lab. And what this allows is that by modifying a little trough here, we can make sure the bottom of the prosthesis is convex. It's another one of my big pet peeves about full mouth implant reconstruction is that if the bottom of your prosthesis is concave, there is no possible way you'll ever clean it. There's an easy, very easy way to make it convex, and I just showed it to you. Here is the lower prosthesis. It has a titanium skeleton and it is wrapped in monolithic acrylic, meaning that the pink and the white are the same piece of acrylic. In the past, we used to process these like we did dentures, where the teeth were one acrylic and the pink denture foundation was another. So what we've gone to for strength is monolithic acrylic, meaning it's all the same piece and is much, much stronger. This view shows you the titanium base or the titanium skeleton that supports the acrylic. This is for strength. Here's the lower hybrid prosthesis off the model. You can see the size of the titanium. It's for strength and the interface between the titanium and the acrylic. You'll notice the bottom of the prosthesis is flat to convex and highly polished, again for cleansability. This is just a fancy picture on a mirror to kind of show the acrylic and the titanium from both angles. I was just as excited to show you the lower tissue as I am the upper. Notice how much keratinized tissue we've maintained, or even in some cases developed over the course of a few months. And this is all paramount to the long-term success of the implant treatment. Here's the mirror view of the same appointment. And again, I just want to point out just how amazing the volume of this tissue is. I know that you have nothing to compare it to if you're watching this video, but I can tell you that this amount of keratinized tissue, because we didn't cut bone and tissue away and we maintained it through prostheses, temporary and permanent, you will not see this in but maybe 1% of all full mouth implant treatments. Here's the final lower prosthesis in the mouth, and you'll notice just like the uppers, teeth look natural. You will never see the demarcation between the prosthesis and the gums unless you pull your lip out and show your friends. Both of these prostheses are screw retained, meaning they're attached by tiny micro screws, and here you see the holes for those. Here's the final upper and lower prostheses, and remember, this is the patient's desire was to have natural color and contours and character. This is the patient's post-operative full face smiling picture. The patient thought he had something stuck under his lower prosthesis, so it gave me the opportunity to remove it and take some more pictures. So what I wanted to show you here was the red that you saw from the temporaries is just about all gone, and with the titanium or the zirconium on the tissues, we tend not to have any allergic reaction, and the tissues return to pink and healthy. The mirror shot just demonstrating how healthy these tissues are. Here is the final x-ray of both upper and lower implants and final prosthesis. When I showed the patient his pictures of his mouth before we started, he didn't recognize his teeth. The ones I showed him were lips retracted of just his teeth. and he thought I was showing him another patient. So the before and afters are really remarkable. Everybody's really happy. And here's the before treatment panoramic image and the post treatment panoramic image. I hope you can appreciate the care and the concern that went into this treatment. We intended, or we hoped, to give the patient fixed temporaries on the first day, but his bone was soft, so we didn't push the envelope. It was inconvenient for him to wear temporaries for 2 months, but again, I would like to think that all my patients, if they understand the difference in the outcomes by being just a little bit more patient, we can get results like this. And we've got dozens and dozens of these cases that I'm trying to document for YouTube and my website gallery. So I hope you'll stay in touch, and thank you for putting up with 36 minutes of this presentation.